Right now, take off one shoe and one sock. Just one foot. Whichever is easier to reach. Place your bare foot flat on the floor in front of you and look at the ankle. Look at the area just above the ankle bone on both the inner and outer side. Look at the lower shin. Look at the top of the foot behind the toes. Now press your thumb firmly into the skin just above your inner ankle bone. Press firmly, not painfully, but with real pressure. Hold it there for 15 seconds. Do not rush this. 15 full seconds. Lift your thumb and look at what remains. Is there an indentation? A small crater in the skin where your thumb was, a depression that sits there, visible, not springing back the way healthy tissue should spring back, filling in slowly, taking 5 seconds, 10 seconds, sometimes 30 seconds or longer before the skin returns to its normal surface. Or look at the skin where your sock sat all day. Is there a groove pressed into the skin above your ankle, a ring of compressed tissue that the elastic left behind when you removed the sock, that is still there now, still visible, still waiting for the tissue to recover from the pressure of a fabric waistband that should leave no lasting impression? If any of that is true, if the indentation sat there when you pressed, if the sock mark is still visible, if the ankle that looks normal in the morning is visibly different from the ankle that greets you when you remove your shoe at the end of the day, I need you to stay with me for the next 20 minutes. Because what you are looking at is not simply swollen ankles. It is not too much salt at dinner. It is not standing too long. It is not your circulation being poor in the vague, nonspecific way that doctors mention when they cannot identify a precise mechanism and do not have time to explain the one that actually applies. What you are looking at is fluid. Trapped, accumulated, stagnant fluid sitting in the tissue of your ankle and lower leg. Fluid that your body's drainage systems were supposed to move, process, and excrete but have been failing to manage at the rate your body generates it. And the reason that drainage is failing, the reason the fluid sits where it sits instead of moving where it should move, is a story that begins not in your ankle but in your chest. In a muscle the size of your fist that has been working every second of your life and that, after 60, begins doing something to the fluid in your legs that nobody ever explained and a 4-minute morning sequence can directly address. I am going to show you exactly what is happening inside that ankle right now. I am going to explain the precise mechanism by which a heart that is functioning, not failing, not diseased, simply aging and changing in the ways that hearts change after 60, creates the fluid accumulation that is pressing against your sock and leaving marks in your skin. And I am going to give you a 4-minute morning sequence that works directly on the drainage pathway. Not the heart itself, not the kidneys, not the diet, the drainage pathway. The system that is supposed to be moving this fluid and has been asking for help every evening when you look down at your ankles and wonder when they started looking like this. Stay through the entire video. Because what I explain about the connection between your ankle swelling and something happening specifically during the night, a redistribution that occurs in the hours between when you lie down and when you wake up, is the piece that explains a symptom most people over 60 have been experiencing and not understanding. The nighttime urination that wakes them at 2 a.m. and 4 a.m. The morning face that looks puffier than the evening face. The paradox of waking up looking more swollen after 8 hours of lying still than you looked when you went to bed. All of it is connected. All of it has the same source. And understanding the source changes everything about how you address it. Subscribe to Dr. Huang right now. This channel exists for people over 60 who want the complete biological explanation behind the things their bodies do that appointments explain incompletely or not at all. Hit subscribe and let us continue. You know this progression because you have been living inside it. There was a version of your ankles that was different. Not necessarily dramatically different. You may not remember a specific moment when you thought today my ankles changed. The change was gradual enough to be invisible from one day to the next, visible only in comparison with how things used to be. A shoe size that has not technically changed, but that requires a larger size late in the day when it did not used to. A boot zip that closes easily in the morning and strains by evening. The deliberate choice of shoes that are slightly larger than you need because the ones that fit at 9 a.m. are uncomfortable by 3 p.m. The avoidance, quietly and without announcement, of shoes with straps across the ankle because the strap leaves a mark that takes hours to fade. You have been accommodating this for years without calling it what it is. Your doctor may have looked at your ankles at some point. Pressed a thumb into the skin the way I asked you to press yours a few minutes ago. Said you have some peripheral edema, very common after 60. Checked your heart, said it is functioning normally. Checked your kidneys, said they are fine. Told you to reduce your sodium intake, Elevate your legs when you can, and come back if it gets dramatically worse. It has not gotten dramatically worse. It has gotten gradually worse, in the way that gradual things do, in the way that allows each incremental worsening to become the new normal before the next increment arrives. And the gradual worsening has never generated a follow-up appointment because it has never been dramatic enough, in any single day compared to the previous day, to feel like something that required urgent attention. But you are aware of it. You are aware of it every evening when you remove your shoes. You are aware of it in the photographs where you notice your ankles. You are aware of it in the moments when you press your thumb into the skin and watch the indentation sit there, slowly filling, and feel a quiet unease that you have been putting aside because there has been no alarm, no crisis, no moment when the unease became something you could act on. This video is that moment. Before I show you the mechanism and the 4-minute sequence, I need to be direct about what requires immediate medical evaluation rather than a home drainage protocol. If your ankle swelling appeared suddenly, over hours to days rather than gradually over months, especially if it is significantly more pronounced on one side than the other and is accompanied by pain, warmth, or redness in the calf of that leg, stop this video and seek evaluation today. Asymmetric, sudden, painful leg swelling can indicate a deep vein thrombosis, a blood clot in the leg that requires immediate medical treatment. If the ankle swelling is accompanied by shortness of breath, particularly shortness of breath that is worse when you lie flat, that wakes you from sleep, that prevents you from lying down comfortably, alongside rapid weight gain of 3 to 5 pounds in a single week, that combination suggests heart failure that has progressed beyond the early compensated stage and requires urgent clinical management, not a home protocol. If the swelling is accompanied by foamy urine, significantly reduced urine output, and significant fatigue appearing over a short period, those together suggest acute kidney involvement that needs evaluation this week. If you have a known diagnosis of heart failure, liver cirrhosis, or significant kidney disease and your swelling is worsening, discuss any change in your protocol with your specialist rather than relying on what I am about to describe. If none of those apply, if what you have is the gradual, bilateral, evening predominant ankle swelling that has been building over months to years in a person who has been assessed and told their heart and kidneys are functioning normally, that is worse by the end of the day and better in the morning, then what I am about to explain is for you. Now let me show you the mechanism. This is the part that changes how you understand your ankles permanently, because once you see why the fluid accumulates where it accumulates and when it accumulates, the 4-minute drainage sequence makes complete, inevitable sense. Your cardiovascular system is a closed loop. The heart pumps oxygenated blood out through the arteries, delivers it to every tissue in the body, and receives deoxygenated blood back through the veins. The arteries have a pump, the heart, driving flow with every beat. The veins have no dedicated pump. They return blood to the heart through a combination of passive pressure gradients, the squeezing action of surrounding muscles during movement, and a series of one-way valves inside the veins that prevent blood from flowing backward. This venous return system works beautifully when you are young, when the valves are tight and functional, when the vein walls are elastic and responsive, when you are moving consistently throughout the day and the muscle pump is activated. After 60, the system faces two simultaneous challenges that combine to produce the ankle fluid accumulation you pressed your thumb into a few minutes ago. The first challenge is cardiac diastolic dysfunction. Your heart has two phases of function: systole, when it contracts and pumps blood out, and diastole, when it relaxes and fills with blood for the next contraction. The majority of people over 60 whose doctors say their heart is functioning normally, who have had an echocardiogram showing normal ejection fraction, the percentage of blood pumped out with each beat, actually have a subtler problem that the standard ejection fraction measurement completely misses. Diastolic dysfunction. The heart muscle, after decades of work, develops a degree of stiffness. Not enough stiffness to impair the pumping phase, the ejection fraction remains normal. But enough stiffness to impair the relaxation phase, the filling that must occur between each beat. When the heart relaxes inadequately between beats, it fills inadequately. When it fills inadequately, the pressure in the left atrium, the chamber receiving blood from the lungs, must rise to push blood into the stiff, non-compliant ventricle. When left atrial pressure rises, pulmonary vein pressure rises. When pulmonary vein pressure rises, systemic venous pressure rises, because the entire venous system is connected. And when systemic venous pressure rises, including the venous pressure in the veins of the legs, the pressure gradient that normally drives fluid from the leg tissue into the venous circulation reverses. Fluid that should be draining from the ankle tissue into the veins stays in the tissue. Fluid that is continuously being delivered from the capillaries into the tissue accumulates faster than the reversal pressure venous system can accept it. Your heart pumps normally. Your ejection fraction is normal. Your cardiologist says your heart looks fine. And your ankles accumulate fluid every day because your heart's relaxation, the phase no one routinely tests, has become stiff and impaired in a way that raises the downstream pressure in your entire venous return system. This is the most common single mechanism behind ankle edema in women over 60 with normal cardiac function tests. Diastolic dysfunction, also called heart failure with preserved ejection fraction, HFpEF, is significantly more common in women than in men, significantly more common after 60 than before, and significantly underdiagnosed because the standard test, ejection fraction, measures the pumping phase rather than the relaxation phase. The second challenge is the venous valve incompetence I described in the varicose vein script, the failure of the one-way valves inside the leg veins that allows blood to pool in the lower leg venous system rather than returning efficiently to the heart. After decades of gravitational load, after the collagen decline of the post-60 decade, after the estrogen withdrawal that removes estrogen's supportive effect on vein wall collagen, the valves that are supposed to snap shut and prevent backward flow of blood in the leg veins begin to close incompletely. Blood pools below each incompetent valve, raises the pressure in the vein segment below it, forces fluid through the capillary walls into the surrounding tissue, and produces exactly the pitting edema you found when you pressed your thumb above your ankle. Two mechanisms: cardiac diastolic stiffness raising the central venous pressure from above, and venous valve incompetence allowing pooling from below, combining in the lower leg venous system to produce a perfect storm for fluid accumulation. Neither mechanism alone needs to be severe to produce the swelling. Together, even at mild levels, they create a fluid accumulation rate that exceeds what the lymphatic system, the third element of the drainage equation, can clear. And the lymphatic system, after 60, has its own problems. As I described in detail in the belly fluid video, the lymphatic system has no pump. It moves only when the body moves. After 60, with the reduced movement of a less physically active lifestyle, with the declining lymphangian pumping of age-related lymph vessel smooth muscle impairment, with a chronic low-grade inflammation that further suppresses lymph vessel tone, the lymphatic system that should be clearing the fluid that the venous system cannot accept is itself running below capacity. Three systems: cardiac diastolic relaxation, venous valve competence, lymphatic drainage, all declining simultaneously, all expressing their combined insufficiency in the same location, producing the ankle swelling that your doctor tested, found no single alarming cause for, and attributed to age and salt. Age and salt are not wrong. They are incomplete. And incomplete explanations produce incomplete treatments, which is why the salt reduction helps a little and the leg elevation helps a little and the diuretic helps a little and the ankles continue to swell by evening because none of those interventions addresses the complete picture. The 4-minute morning sequence addresses all three systems simultaneously: cardiac diastolic function, venous return, and lymphatic drainage, in a sequence that is specifically timed and specifically ordered to produce the maximum drainage effect before gravity has had a single second to begin pulling fluid downward into the ankles that just spent 8 hours letting some of it resolve. But before I give you the sequence, I need to explain the overnight redistribution, because this is the piece that connects everything. When you lie down at night, gravity stops pulling fluid into your lower legs. The fluid that has accumulated in your ankles and lower legs during the day, sometimes hundreds of milliliters of it, is now free to redistribute. It re-enters circulation through the capillaries and lymphatics as the hydrostatic pressure that was trapping it in the tissue is removed. Your blood volume temporarily increases. Your kidneys detect the increased blood volume and produce more urine, at 1 a.m., at 3 a.m., at 4 a.m., at the times when you have been waking to use the bathroom and explaining it as bladder issues or simply how sleep is now. It is not bladder issues. It is your ankles draining. But here is the paradox. Not all of the ankle fluid drains to the kidneys during the night. Some of it redistributes upward, to the face, producing the morning puffiness. Some of it redistributes to the hands, producing the finger tightness in the morning. Some of it stays in the lower leg tissue, producing a residual edema that is present when you wake, that is less than the evening maximum but more than the zero it should be after 8 hours of lying flat. And the moment you stand up, the moment your feet touch the floor and gravity reasserts itself, the fluid that remained begins to be joined by new fluid delivered from the capillaries, and the day's accumulation begins again from a residual base rather than from zero. The 4-minute morning sequence interrupts this cycle at its most vulnerable point, the moment before you stand up, when the overnight partial drainage has given your lymphatic and venous systems their best opportunity of the entire day, and when 4 minutes of specific movement in the horizontal position can clear the residual fluid before gravity reclaims it for the day's accumulation. Let me tell you about someone I will call Harriet, though a different Harriet from the one in the belly fluid video, because this name, like many in this series, belongs to multiple women of this generation whose stories share the same pattern even when their specific journeys are distinct. 71 years old. Former secondary school teacher. A woman who had spent 35 years on her feet, standing at the front of classrooms, walking between desks, climbing stairs between buildings, moving continuously through the particular physical demands of a profession that most people outside it do not recognize as physically strenuous. She had retired 4 years earlier. And within 18 months of retirement, within 18 months of transitioning from a profession that kept her moving 8 hours a day to a life that was, by comparison, significantly more sedentary, her ankles had begun to change. She had not immediately connected the retirement and the ankles. It had not occurred to her that the movement her profession had imposed was doing something specific for her venous and lymphatic drainage that the retirement had quietly removed. She had attributed the ankle swelling to age, to the natural deterioration that she had been watching in her peers, to simply arriving at the decade when these things happen. She came to me because her ankles had begun to concern her daughter, who had insisted she seek a second opinion after a first appointment attributed the swelling to age and mild venous insufficiency and recommended compression stockings. She was wearing the compression stockings. They helped during the day, reducing the accumulation while she wore them. Every evening when she removed them, the swelling that had been suppressed returned within an hour. The stockings were addressing the consequence while the mechanism continued. When I asked about her sleep, she described the same pattern I described earlier. 2 to 3 nighttime urinations, consistently, regardless of how much she drank in the evening. Morning face that she had assumed was simply how her face looked now. Finger tightness in the morning that resolved through the day. Ankles that were better in the morning than in the evening but never truly flat even after a night of lying still. I asked her to describe her first action every morning. She said she swung her legs out of bed and stood up immediately, the habitual movement of a lifetime of early mornings. The moment she stood up, I told her, whatever overnight drainage had occurred in her ankle tissue was immediately challenged by gravity reclaiming the territory. The 4-minute sequence I was about to teach her would happen in the horizontal position before standing, working with the gravity advantage that overnight lying had created rather than immediately surrendering it to the upright position. Her echocardiogram, when we reviewed it, showed what I expected: normal ejection fraction of 62%, normal systolic function, and a finding that the reporting cardiologist had noted as grade 1 diastolic dysfunction, impaired relaxation, described as mild, age-appropriate, not requiring any intervention. Grade 1 diastolic dysfunction. Age-appropriate. Not requiring intervention. These are not the words of a finding that explains her ankle swelling, at first read. They are words that dismiss a mechanism as expected and therefore unactionable. But grade 1 diastolic dysfunction, the most common cardiac finding in women over 65 in the absence of other pathology, produces exactly the slightly elevated left atrial pressure that transmits as slightly elevated pulmonary venous pressure that transmits as slightly elevated systemic venous pressure that compounds the venous valve incompetence in the legs to produce exactly the bilateral, evening predominant, pitting ankle edema that Harriet had been wearing compression stockings to manage. The cardiologist had correctly identified the diastolic dysfunction and correctly classified it as mild. The classification as not requiring intervention referred to cardiac intervention. No medication, no procedure was warranted at this grade of dysfunction. It did not mean the finding had no downstream consequences. It did not mean those consequences were not addressable through non-cardiac means. It simply meant the heart did not need treatment. The ankles did. And the pathway to address them ran through the drainage systems, the venous pump, the lymphatic system, that were downstream of the cardiac mechanism and directly accessible through the 4-minute morning sequence. Harriet implemented the sequence every morning for 6 weeks before her next appointment with me. She stopped standing up immediately upon waking and spent 4 minutes in the horizontal position first. She reported, at 4 weeks, that the evening sock marks were less deep than they had been, not absent, but less deep. At 6 weeks, she reported that the morning ankle measurement she had been taking with a soft tape measure, at the same position, at the same time each morning, before any standing, had decreased by an average of 1.8 centimeters compared to baseline. The overnight drainage that had been clearing 60 to 70% of the day's fluid accumulation before the 4-minute sequence was clearing 85 to 90% after it, because the sequence was actively assisting the drainage that had previously been left entirely to passive overnight redistribution. She continued wearing the compression stockings. They remained useful for the daytime period. But the combination of the morning sequence reducing the residual edema baseline before the stockings went on, and the stockings preventing daytime accumulation, produced a result that neither alone had achieved: ankles that were significantly closer to normal throughout the day than they had been at any point in the previous 2 years. Here is the 4-minute morning sequence. This must be performed before your feet touch the floor. Before you stand up. While you are still horizontal. This timing is not arbitrary. It is the entire mechanical basis of why the sequence works. You are using the gravity advantage of the overnight lying position to drain fluid that would otherwise be immediately reclaimed by the gravitational pull the moment you stand. The sequence has 4 components. Each component targets a different aspect of the drainage mechanism. The order matters. The first component, 30 ankle pumps on each foot. 60 total. 90 seconds. Lying flat on your back, extend both legs fully. Point your toes away from you as far as they will go, full plantar flexion. Then flex them back toward your face as far as they will go, full dorsiflexion. 1 complete cycle. Do this 30 times on each foot, or 30 times with both feet simultaneously if coordination allows. Slowly and completely, the full range of motion, not a small flick. The mechanism is specific. The calf muscle, the gastrocnemius and soleus, is the most powerful venous pump in the body. When these muscles contract with the ankle in dorsiflexion, they squeeze the deep veins of the lower leg and drive blood upward toward the knee and beyond. In the horizontal position, with no gravitational resistance to upward venous flow, every calf muscle contraction during these ankle pumps produces more effective venous return per pump than the same movement would produce while standing. You are activating the most powerful venous pump in the body at the moment when its mechanical efficiency is highest, before gravity has been allowed to reassert the downward pressure it will maintain for the rest of the day. 30 pumps each foot. 90 seconds. This is the venous return component. The second component, knee-to-chest holds. 5 repetitions. 45 seconds. Still lying flat, bend both knees and bring them simultaneously toward your chest. Hold them there with your arms crossed over your shins, drawing the knees as close to your chest as is comfortable. Hold for 10 seconds. Release. Repeat 5 times. This position does 2 things simultaneously. It compresses the abdominal cavity from below, raising intra-abdominal pressure slightly, which assists the return of lymphatic fluid through the thoracic duct, the main lymphatic drainage channel that empties into the venous system at the base of the neck. Every increase in abdominal pressure during the knee-to-chest position creates a pressure gradient that drives lymph upward through the thoracic duct with greater efficiency than the passive chest breathing that normally provides this pressure. It also briefly compresses the inferior vena cava, the large vein that returns blood from the lower body to the heart, in a way that, on release, creates a suction effect that assists venous return from the legs. The alternation of compression and release, 5 times over 45 seconds, is a manual assist to the venous return mechanism that the diastolic dysfunction is making slightly insufficient. 5 repetitions. 45 seconds. This is the thoracic duct and venous suction component. The third component, the elevated leg drainage with active ankle movement. 60 seconds. Raise both legs off the bed, lifting them together, holding them at roughly a 45 to 60 degree angle from the horizontal, supported by the abdominal muscles or by leaning against the wall if you position yourself at the foot of the bed. Hold this elevation while performing 10 slow ankle circles in each direction and 10 alternating ankle flexes. This component reverses the gravitational advantage completely. For 60 seconds, gravity is actively assisting drainage from the ankle and lower leg toward the body center rather than pulling fluid downward into the ankle as it will do for the entire remainder of the day. The active ankle movement during the elevation adds the muscle pump action to the passive gravitational drainage, producing simultaneous gravitational and muscular assistance to the same drainage pathway. 60 seconds. This is the gravitational reversal component. The fourth component, the lymphatic hand drainage. 30 seconds. Sit up slowly from the elevated leg position. Sit on the edge of the bed. Place the flat of your fingers, not the fingertips, the flat of the entire finger surface, on your lower shin just above the ankle. Apply light but firm pressure and stroke upward toward the knee in one slow, continuous motion. Not downward. Always upward. Always toward the knee. 10 strokes on each leg. 20 strokes total. This is simplified manual lymphatic drainage, physically moving the superficial lymphatic fluid that has accumulated in the subcutaneous tissue of the lower leg from the ankle region toward the popliteal lymph nodes behind the knee, where it enters the deep lymphatic channels returning to the thoracic duct. This is the same technique used by lymphatic therapists in clinical settings, simplified, self-applied, and performed at the exact moment when the overnight partial drainage has created the most favorable tissue conditions for the manual technique to move what remains. 10 upward strokes each leg. 30 seconds. This is the lymphatic clearance component. 4 components. 4 minutes total. Performed in sequence, before your feet touch the floor, every morning. The fluid moved during these 4 minutes would otherwise be there when you stood up, adding its volume to the new fluid delivered by the first hour of upright posture, compounding the day's accumulation from a residual base rather than from zero. Now let me give you the broader protocol, the dietary, supplemental, and lifestyle components that address the 3 mechanisms: diastolic dysfunction, venous valve incompetence, and lymphatic drainage insufficiency, throughout the day rather than only in the morning. The dietary protocol for diastolic cardiac function. Diastolic dysfunction, the stiffness of the heart muscle between beats, is driven and worsened by the same systemic inflammation and oxidative stress that drives every other age-related tissue change I have described across this series. The anti-inflammatory dietary protocol I have described in multiple previous videos: extra virgin olive oil replacing seed oils, oily fish 3 times per week, daily turmeric with black pepper and fat, regular beetroot, daily garlic, addresses diastolic function through the reduction of the inflammatory cytokines that directly impair cardiomyocyte relaxation. But there are 2 specific nutritional additions for diastolic function that I have not mentioned in the context of ankle swelling specifically. Magnesium, 300 mg of magnesium glycinate at bedtime, as I have recommended across multiple videos, is specifically required for cardiac muscle relaxation between beats. Magnesium is the mineral that allows the calcium that entered the cardiomyocyte during contraction to be pumped back out during relaxation. Without adequate magnesium, calcium remains elevated inside the cardiac muscle cell between beats, the cell cannot fully relax, and diastolic stiffness worsens. The majority of people over 60 are significantly magnesium insufficient. The majority of people over 60 with ankle swelling from diastolic dysfunction are magnesium insufficient and have never had their magnesium status assessed, because magnesium is not included on a standard metabolic panel. 300 mg of magnesium glycinate at bedtime. Every night. For a heart that needs to relax more fully between beats, this is the most directly targeted nutritional intervention available without prescription. Coenzyme Q10, 200 mg daily with the largest meal. CoQ10 is required for the mitochondrial energy production that powers the calcium pumps responsible for cardiac muscle relaxation. The same decline in CoQ10 synthesis after 60 that impairs gum tissue fibroblast energy production and peripheral tissue maintenance also impairs the cardiac muscle cell's ability to power its own relaxation machinery. Statin medications, taken by a significant proportion of people over 60 for cholesterol management, additionally deplete CoQ10 by blocking the same biosynthetic pathway that produces it. If you are on a statin and have ankle swelling, the connection between statin-mediated CoQ10 depletion and diastolic dysfunction is a conversation worth having with your prescribing physician. 200 mg of CoQ10 with fat at your largest meal, every day. The venous valve support protocol. Rutin, 500 mg daily, from buckwheat if accessible or from supplement form. Rutin is the plant flavonoid with the most specific, most replicated clinical evidence for supporting venous valve collagen integrity and reducing capillary fragility. Multiple clinical trials in adults with chronic venous insufficiency have shown measurable reductions in leg heaviness, ankle swelling, and venous pressure following rutin supplementation over 8 to 12 weeks. It works by strengthening the collagen matrix of the vein wall and the valve leaflets, giving the failing valves the structural support that age-related collagen decline and estrogen withdrawal have reduced. Buckwheat, cooked whole buckwheat groats, not buckwheat flour or buckwheat bread, provides rutin in the highest concentration of any accessible food, alongside the protein and fiber matrix that improves its absorption relative to the isolated supplement. 2 to 3 servings per week of whole cooked buckwheat provides a meaningful rutin dose that complements the supplemental form. Horse chestnut seed extract, standardized to 50 mg of essen, twice daily with food. Essen is the active compound in horse chestnut that reduces the capillary permeability that allows fluid to leak from the venous capillaries into the surrounding ankle tissue. Multiple randomized controlled trials have confirmed its efficacy for chronic venous insufficiency, specifically reducing ankle circumference and ankle fluid volume in people with venous valve incompetence. It is available at most supplement retailers and health food stores. 50 milligrams of standardized Essen twice daily. With food. The sodium management protocol, because sodium matters, just not in the way most people understand it. The standard advice to reduce sodium for ankle swelling is correct but incomplete. The specific advice is this. The sodium that most directly drives ankle fluid accumulation is not the salt shaker. It is the hidden sodium in the evening meal, the sodium consumed in the hours when the venous and lymphatic drainage systems are at their most sluggish and the body has the least time before lying down to process the sodium load before it drives fluid into the ankle tissue. For every gram of excess sodium consumed, the body retains approximately 4 cups of water in the surrounding tissue. Evening sodium, from cured meat, from cheese, from canned foods, from sauces, from restaurant meals, is retained overnight in the tissue and contributes to the residual morning ankle edema that the 4-minute sequence is working to clear. The practical protocol is this. Before 12 p.m., moderate sodium management but no restriction anxiety. After 12 p.m., active sodium minimization. The evening meal and any evening food should be the lowest sodium intake of the day. This specific timing of sodium management, later day restriction rather than all-day restriction, produces a more meaningful reduction in ankle fluid accumulation than equivalent all-day restriction because the evening and overnight hours are when the tissue has the least drainage capacity to manage the fluid that sodium draws into it. The evening drainage preparation sequence, complementing the morning sequence by preparing for the overnight drainage window. Every evening, 60 to 90 minutes before bed, 15 minutes with both legs elevated against the wall or over the back of the couch, heels above heart level. During those 15 minutes, perform the same ankle pumps from the morning sequence, 30 pumps, and the same upward leg strokes, 10 strokes each leg. Then stand up and go to the bathroom within 30 minutes. What you will produce in the bathroom within 30 minutes of this sequence will surprise you the first time it happens. The fluid that has accumulated in your ankles throughout the day, the fluid that would otherwise redistribute upward during the night and wake you at 3 a.m., has been drained deliberately, while you are awake and in control, into the renal circulation that processes it and produces it as urine. You drained your ankles on your schedule instead of being woken at 3 a.m. while your body attempted the same drainage in the horizontal position with gravity no longer providing the downward pull that was the only thing keeping the fluid in the legs during the day. This evening sequence and the morning sequence together bracket the overnight period, draining as much fluid as possible before lying down and clearing the residual as completely as possible before standing up. The overnight period becomes a maintenance window rather than the primary drainage event, and the 3 a.m. waking begins to reduce as the kidneys receive the fluid redistribution earlier in the evening rather than throughout the night. 5 steps. Starting tonight and tomorrow morning. Tonight, perform the evening leg elevation sequence. Find a wall or the back of your couch. Lie down and elevate both legs for 15 minutes. Do the 30 ankle pumps during the elevation. Do the 10 upward strokes on each leg when you sit up. Go to the bathroom within 30 minutes. Notice what happens. Tonight, take 300 milligrams of magnesium glycinate with a small glass of water at bedtime. This is the cardiac diastolic support that begins working during the very overnight period that your heart's relaxation has been impairing your ankle drainage. Tonight, set tomorrow morning's intention before you sleep. When the alarm goes off tomorrow morning, do not stand up. Stay horizontal. 4 minutes. The ankle pumps, the knee to chest, the elevated leg drainage, the upward strokes. In that sequence. Before your feet touch the floor. This week, buy horse chestnut seed extract standardized to Essen, Coke 10 200 milligrams, and rutin 500 milligrams. These 3 supplements together address the venous valve, the cardiac relaxation, and the capillary permeability mechanisms that your ankle swelling is reporting simultaneously. None of them is a diuretic. None of them removes fluid by force. All of them support the drainage systems that are supposed to be moving the fluid, so that the fluid moves through the pathways designed for it rather than accumulating in the tissue designed for other purposes. At your next appointment, ask your doctor specifically about diastolic function. Not ejection fraction. Ask about diastolic function. Ask whether your echocardiogram included diastolic assessment and what the result was. Ask about your magnesium level. Ask whether horse chestnut or CoQ10 is appropriate alongside any medications you currently take. These are the specific questions that address the specific mechanism, and they are the questions that will transform your ankle swelling from a passive, accepted feature of your post-60 landscape into an understood, targeted, actively managed process with a direction of improvement that your morning ankle measurement can confirm. Take that measurement tomorrow morning. Before the 4-minute sequence, press the same spot above the ankle bone. Note the grade of pitting. Use a soft tape measure at the same position if you have one. Write the date and the measurement. At 8 weeks, repeat both assessments. The direction of change in those numbers, not dramatic, not overnight, but measurable and consistent over weeks of daily application, is your drainage system reporting that it is receiving the help it has been asking for every evening when you look down at the ankles that told you something was wrong. How old are you? Write your age in the comments right now. I ask because the rate of diastolic stiffening, the degree of venous valve incompetence that typically accumulates by decade, the specific lymphangin pumping decline that compounds the drainage failure, all of it progresses differently between 62 and 76. Your age tells me what this channel needs to address next. And tell me this, how many seconds did the pitting take to fill in when you pressed your thumb above your ankle at the beginning of this video? Write the number in the comments. 5 seconds, 10 seconds, 30 seconds, more than 30 seconds. I want to know the grade of fluid accumulation this audience is carrying, because that number tells me how long the drainage systems have been failing and how urgently the morning sequence is needed. If someone you love removes their shoes at the end of every day and looks down at ankles that are different from the ankles they woke up with, who has been told it is age, it is salt, it is something to manage rather than something to understand, send them this video. Their ankles are not simply swollen. Their drainage systems have been asking for 4 minutes every morning for longer than anyone realized, and nobody told them the 4 minutes existed. The fluid sitting in that ankle tissue right now is not there because the body failed. It is there because 3 systems that were designed to work together have each lost a fraction of their function, and the fraction lost from each one has combined into a whole that produces the visible, traceable, sock-marking accumulation you found when you took your shoe off at the beginning of this video. 4 minutes. Before your feet touch the floor. Tomorrow morning. The ankles that press back against your thumb will tell you, within 2 weeks, whether the drainage systems are receiving what they needed. They will tell you in the only language they have ever used. The fluid that is no longer there.